would you like to see erosions in the metacarpal heads? Margins, yeah. Any
subarticular?
can be subarticular region or just juxtarticular region, but most of the time we look for erosions in the metacarpal in rheumatoid arthritis. So where would you like to see erosion? Anywhere in the metacarpal head, any particular location? Or radial side, okay? Where the erosions are, because there is natural irregularity on the ulnar side. So if you look at the ulnar side, you may miss or overcall. So on the radial aspect of the metacarpal head or any erosions. This is your first. Ulnar side is normal. So I use N for normal on the ulnar side irregularity and always look on the radial side. Okay. So how would you diagnose anybody? You can out. So you have been given X-ray. How would you differentiate about the condition we just mentioned, osteo, inflammatory gout, CPPD? How would you differentiate?
History first, then X-ray find specific for the specific disease, then lab for X-rays available.
True. So you said everything right. So we've given you 2 X-rays of the hands. So how would you look at criteria you use on X-rays now?
Starting from the bone density and then coming to the interest like the specific sites involved in RA or the specific sites involved in the OI, that would be different. So that would be done in that case.
Yeah, so right thing. Yeah, number of joint involvement. Yeah, exactly. Distribution you wanted to say. Rheumatoid is particular. Very good. So we just need to see which type of or which joints are involved mainly in that condition. That makes our life slightly easier for that. Distribution is the first thing. And then other criteria are multiple criteria in that joint. Somebody said erosion, very good. Symmetry, excellent. Anything else? So you're seeing a joint which is abnormal, but you look in that joint. Character, what does it mean character? The character is clinical, fixed or migratory. Somebody said distribution wrist in rheumatoid, very good. So you look at the density marks initially and erosion, somebody said. You look for soft tissues, fine. You look for any increased density, okay, and alignment of the bones. Soft tissues, very good. Soft tissues means calcification density or all these. Osteopenia, sorry, I forgot, because that is hallmark of inflammatory arthropathy, especially rheumatoid. Okay, so these are the criteria we use to look at plain X-rays and characterize that, okay, this falls in that category. Okay.
Excuse me, sir. I want to say that Dr. Aisha has lost her connection for this session. I have just sent
recording in progress.
Yeah, it is doing it now.
Yes, it's fine now.
Okay. Okay. So distribution, we're just looking at hands and feet and feet, including the ankle joints. So when we look at the distribution as interphalangeal joint, which is DIP and IP joint, and then we look at the MCP joint and part of the wrist, or which part of the wrist joint is involved. And you can look at these X-rays in any order. You can start from the wrist onwards or from the top to bottom in X-ray or chest X-ray. you should cover all the areas that you don't miss anything. So in hand, there are around more than 20 joints on one side, more than that. So what you have to do is, if you are looking at your, you have to magnify it. But if you're looking at X-ray or hard films, magnifying that you're not missing any subtle erosion, subtle abnormal. And if phalangeal EP joint, we're looking at the so that we look at these and characterize. So, any question so far? This is a general overview. So, what is osteoarthritis? Very common in hand. Joints or both joints are more affected in this case. Anybody can involve the DIP and interphalangeal joints are mainly involved in, yeah, somebody, absolutely. Basically involve the interphalangeal joint more commonly, and that main phalangeal joints are involved. Minute, okay. Look at this X-ray. You can see that there are multiple joints involved. So is it symmetrical? Is it bilateral? Of course, it is. So, absolutely. But the chain or not? Maybe reduce. Look at the densities. Now, density is maintained, and interphalangeal joints are mainly involved. MCPs are a little bit of arthritis in the STT, which is scaphoid, trapezium, and trapezoid, and first CMC joint. Okay, let's magnify these. So we are looking at that. We can see that this can change point. Is it uniformly reduced or is it uneven? I would say it's uneven.
It's uneven.
Yeah, yes, anywhere will lead to uneven joint reduction. Where the pressure is, there will more loss of joint space. Where the less pressure, less joint space lost. So you can see that joint space is slightly reduced here, not on the ulnar aspect. And if you look at this one, again, more in the center, and also ulnar side, there are big osteophytes on the medial side. So, joint space reduction, osteophytosis, you can see the subchondral collapse. Let me go further. You can see that there is osteophyte space reduction here, but we'll start seeing the subchondral situation. And this is, we see Siegel's Gulving sign, they call it. This is because of early subcentral collapse. The bone, they just fit into each other, just like jigsaw. So that is very typical of. Few people call it erosive osteoarthritis. It is a sign of erosive osteoarthritis, but there is no erosion yet. Okay, so that makes it, I think, just simple osteoarthritis in my opinion. So, if the loss of joint space, marginal osteophytosis, some collapse, but look at the bone margins in both cases. They are different cases, but they are very sharp. There is no fuzzing of the periosteum or cortical outline. This is very typical of osteoarthritis. So, DIP joints involvement, osteophyte formation, possible subchondral collapse, and sharp margins osteoarthritis. Okay. Now, in this case, look at both sides. So it is symmetrical now, but the problem is same. Osteophyte formation, kind of jigsaw type of appearance of the IP joint of the little finger. It is, asymmetrical because marginal osteophytes is more prominent on one side. Again, bone margins are very sharp, so it is typical of osteoarthritis because location is typical, appearance is typical. And just to show you how it looks like on ultrasound, because just want to rule is there any associated synovium. I just in that in a minute. But look at the bone margins; they're very sharp. Again, there's no joint diffusion. Fight again, very sharp. That's how it look on ultrasound. Now, the MCP joint, it mainly involves the second and third MCP joint. Okay, but you can see that the joint space is reduced, but not marginal osteophytosis. This is very important because in certain condition, we discussed that we will have marginal osteophytosis, and this will put in the different category. Now look at the IP joints. We see marginal osteophytosis, joint space is reduced, subchondrosis formation here, little things here, and similar thing here, maybe a lysis formation there, formation there, some osteophytosis, but we don't see it here. And more mobile compared to the in osteoarthritis, we significant points in the MC, and these two TP joints are. This is a very, very important point. Just remember that. So in the wrist, so which joints are involved? Which, as I just discussed, that is DT and first CMC joint, which is typically involved in basically or involved. Everybody who's working hard or use their computer will. So unfortunately, all our generation or your generation will lot of, and that can be. But again, most important thing is that in osteoarthritis, radiocarbon, not the radioscaphoid joint is just especially joint. So look at patient's example. So radiocarpal joint is okay. STT joint space is reduced, and now we see that first CMC is not bad here. Now looking on the right side, radio use maybe sub. Now arthritis is CMC. यहाँ पे आपको osteophytes and calcification नजर आ रही है और a bit of subluxation भी नजर आ रहा है. So significant on the STT is not, but so it's osteoarthritis, subluxation of the CME joint. ठीक है? And different combination can happen, but most important thing is that is spared osteoarthritis. So, any condition you remember where you can have osteoarthritis in the radiocarpal joint or rheumatoid arthritis? Yeah, you can. I'm waiting for somebody to. Any condition with osteoarthritis in the radiocarpal joint. If there is a distal radial fracture that particularly involves the alignment of the articular surface, it can lead to secondary arthritis of the radiocarpal joint. We see patient as a cold. Even there can be some arthritis of the radiocarpal joint. So the summary was the IP MCP joints are old, reduced joint space, but no osteophytosis. Joint is preserved. Very well. It is margins, gulving appearance, if you want to call it, and but they can be subcondylosis, typical appearance, but distribution. IP joints, second and third MCP joint without osteophytes, and radiocarpal joints failed. So, any question about that? Anything you're not sure about? I can.
Third, the nodes that are formed in OA, like the Heberdens and the butchered nodes, are they advanced cases, and are they due to the soft tissue swellings?
They're bone things. So they are osteophytes. Go back, if I can show you. Let me go back. Go back. Wait. Oops. So I'm sure, don't show, but if you see that these osteophytes on the dorsal aspect, they will form Heberden nodes. So most of these are due to osteophytes which are projecting outside. There can be some, but mainly these are osteophytes. That's why mainly. And when they have some problem, it is due to inflammation. I'll discuss that in a minute.
Okay.
Okay. So yeah, Heberden nodes or Bouchard nodes, they are just osteophytes mainly. Okay, when they project, they will be basically can cause pain. Okay, any question? No question, so I can move. Okay, so moving on to erosive osteoarthritis or inflammatory osteoarthritis. I should have typed osteoarthritis. So why we get erosions in osteoarthritis? And is why do we get synovitis in osteoarthritis? It's not synovial disease. It's just a degenerative disease, wear and tear. So there's explanation here. So this is a normal joint, cartilage, nice joints. There's no inflammation. With the wear and tear or degenerative changes, manual work or somebody using their hands or feet a lot, that uneven loss of cartilage as we expect in osteoarthritis. Oh, sorry. Okay. So when it happens, there some bony changes. It can be subcondylosis formation or bone. But what happened? What is synovium? This is the lining of the joint. So this is normal lining, which is okay in normal joints. But what happened in that case, because joint is now uneven, synovium gets trapped in this area. And when it gets trapped, it gets inflamed. It can start giving you pain. There's of arthritis, but it can give acute pain. Even people with osteoarthritis, they will present that I started to have more pain because due to some reason, the synovium gets more trapped and a bit more in awkward position or done something, lead to inflammation of the synovium, and that can be inflamed in the whole or side of the joint. It can be anywhere. Synovium is inflamed, it can cause erosion of the bone or subcondyles. So this is the inflammation in degenerative osteoarthritis. What happens in inflammatory arthritis? Inflammation comes first. That eats the cartilage, and that synovium also produces articulations. Arthritis comes first, and that causes trapment of the synovium and can lead to inflammation and erosions later on. So arthritis and erosion, we call it or inflammatory arthritis. This explanation, I can do it again, but this will, once you get this, I think things will fall. Any question about it?
Sir, can you please summarize it once more?
So let's go back. So this is a normal joint. So when osteoarthritis in it, there will be loss of cartilage, uneven loss of cartilage means uneven space reduction, as we saw in the cases in the IP joints. You can see that no synovium because joint is not normal in that joint because working normally now because of uneven functioning of the joint, synovium is trapped, inflamed, and when it's inflamed, it will reduce, and that's osteoarthritis because osteoarthritis came first, leading to osteoarthritis came to inflammation of synovium and inflamed synovium now erosion. This sequence we call it osteoarthritis, and it's completely reverse in primary arthritis, where the erosion of synovium, that erosion of the cartilage, to osteoarthritis. We call it secondary osteoarthritis. I can go over it.
Thank you so much.
Everybody clear on that? I just want somebody to that is okay. Good. And then, of course, there can be inflammation of the soft tissue. Forget about soft tissues. A few times we can see that swelling is there over the joint, and it's more under the skin as compared to in the joint. Ultrasound can tell us about. But again, once inflammation is noted, it will issues as well. Arthritis, osteoarthritis. The osteoarthritis is there and lead inflammation. We decided that and of second and third without osteoporosis is typical distribution in the hands. But progressive osteoarthritis typically occurs in the IP joints. Okay. And it is typically as we in elderly females or postmenopausal females. So same thing as we saw marginal osteophytosis, there is central collapse, and which gives a Siegel sign. But now we started to see articular surface irregularity. Okay, so we can see that maybe somewhere there on the corner, but now we can see the big marginal. You can see this uneven collapse of the articular surface, which is not in the periphery, which is in the center of the articular surface, and articular surface irregularity. Look at the margin. Okay, and look at the soft tissues. Tissues here, swollen. So there's an erosive osteoarthritis. Same thing here. Which is sharp. There's a small compared to that, and no bony margins are sharp, and there's deformity in this case at this moment. Typical of erosive arthritis. The condition lead to I just want anybody to shout. Rheumatoid can give, but psoriasis or seronegative arthritis. It can give erosion.
So it evolves into phalangeal.
Exactly. Typically, margins are not sharp in these days because of perish. What type of deformities occur? Seronegative arthritis, especially rheumatoid. Potent one type of deformities, which is sagittal alignment, which goes, okay, it can be like that, or swan neck, the neck goes the other way. Arthritis, it can be on the sideways, it can be valgus or varus stiffity, on one side. Alignment in this case compared to or show you another example. You can see that multiple are involved in loss defined collapse there. You can see that there's a bit more collapse now. Look at the alignment now. It's gone on the under S. So it is clearest deformity at the on the right side. Okay. So this alignment is side on the extension on the okay. So just go back. So how we see that on ultrasound? Look at multiple joints are involved. Marginal is slightly narrowed. Maybe a little bit of joint space reduced in the second and third MCP joint, which is typical. But in the interphalangeal joints, quite and even outline is not very clear. You can see that there is possible articular surface collapse, swollen. Easily say that is or seronegative possibility, but all the other change cause of so can this be erosion? So with ultrasound, and we can of this finger, and you can see that there is marginal osteophytes, and there is maybe some erosions on this side. So because there are other changes, and only joint is involved with erosion, we had previous imaging was slowly progressing, so it was diagnosed as osteoarthritis because other things osteoarthritis are also present. So some erosion as a way, but erosion will all occur in the interphalangeal joint. So there will be marginal osteophytosis, central collapse, margins. You will see osteoarthritis of the MC third. Similar to osteoarthritis, you will have STT joint in first CMC osteoarthritis, similar to the osteoarthritis, but no erosion in these places, and it typically occurs in LV females. So, about this. It's
Yes,
basically,
sir.
it's basically osteoarthritis, which led to inflammation, and now we're seeing erosion. So, tend to call it erosions when I see articular surface, then I call it erosive osteoarthritis, not when there's a sign. But simple books say some authors describe Siegel sign or Gull as sign of erosive osteoarthritis. It's completely all right. But as far as you know, this is part of osteoarthritis. Any question, I can go over it again if you want, but I just need you to tell me that everything is understandable at this point.
Can you just explain osteophytes on this ultrasound image? Can you just point it out? Osteophytes are.
Yeah, sure. So let me go back to the previous ultrasound because that will make your life easy. Okay. Yeah. So can see that osteophytes? It's got very sharp. It is just a bone outline should be like that. Okay, but something which is projecting out, not this is osteophyte. So this is something projecting, but again, sorry, it is continuous with the cortex, but bulging outside. Osteophyte. Now, if I go to my when I saw that, I just want to show you the erosions. You can see that outline is not a discontinuity there, and there's quite a bit of synovial. Okay, you can see that there's quite a bit of synovial thickening spot, and this erosion gives us an idea that there's some inflammation which is producing the erosion in. Okay, this is wood in these cases. I don't on these, just show you that add or reduce anything, plain X-rays, hallmark of diagnostic priorities. So
One question is explain the various and with respect to bone will be our standard and what will be the orientation point of view?
very good. It's always a distal part. It's always a dislocation. If want to say anterior dislocation or posterior dislocation, anteriorly dislocation. If you're looking at the knee, tibia has gone forward, it means tibia has gone posterior dislocation. Same thing is in joints. So this is the radial side on my right. You can see that it's a little bit towards the radial side, the valgus. You always look at the distal part of the two serous, valgus, anterior and posterior. Okay.
Yes, sir. Okay.
In that case, you can see that it's going towards the in the middle and going out towards the ulnar aspect.
So this is varus in this case.
Exactly.
Okay.
Moving to the CP, how many people in routine life, in daily reporting, do that?
Well, not seen many CPPT in routine.
Exactly, I Pakistan, but they are there. We don't know it is there. Okay, so you start seeing a lot of these. So we look at the CPPD. Is what is CPPD? Disease. So phosphate, or they also call it basically. Call it. What is the distribution of CPPD? Involved. It is also involved a third. And so you will say, even the osteoarthritis typically involves these two joints. There's subtle difference. And the wrist, we know that osteoarthritis doesn't involve the radiocarpal, doesn't involve the radiocarpal joint. So morphology difference in these two joints, MCP joint, and in the wrist, it involves the radiocarpal, which is involved in osteoarthritis. So these are the differences, but other presentation is almost same. So what is the phenomenon to that? As is it's a calcium pyrophosphate is a crystal with deposits in the soft tissues, all soft tissues. Synovium, ligaments, tendon, joint capsule, or all type of soft tissue, even in the subcutaneous tissues. And other thing is when it is in the synovium or cartilage, it destroys the joint like osteoarthritis. And that is associated with large subchondral cysts. We call it geodes. Okay, so geodes are basically large subchondral cysts. The two things you need to remember: calcification can occur anywhere, and there's destruction of the joint or crystal deposition lead to osteoarthritis and large subchondral cysts. So, where does it calcify? Calcification is in the TFC and in the ligaments and also surrounding soft tissues. Slide. This is Resnick's. I copied that. So you can see the calcification. It can be very faint. It can be in the cartilage. Can you see that? Its cartilage is calcified in the lunate and tricuspidal bone. And there's also calcification in the scapholunate ligament, which is in this here. So what happens when there's a calcification in certain? I just want everybody to tell me what happens when there's a calcification.
Mobility reduces.
Or elasticity is reduced. Okay. So whenever all these structures are very elastic. They are cushion effect mainly, or they are keeping things together, ligaments. They're very elastic and come back like a rubber band, very tight rubber band. So they become rigid, and they are more prone to rupture and more prone to destruction. So when these are torn, when they calcify, they get torn, and that can affect the alignment of the joint. Okay. Now, this is, you can see that there's a faint calcification in the TFC area, and there's some calcification in this is lunate, and this is tricuspid ligament, or lenotricuspid ligament calcification. So it means there's some calcification, but it doesn't occur in osteoarthritis. Now look at now what, as I said, this typically involves radioscaphoid joint. Okay, I need to do couple, but radioscaphoid is the initial. Look at the radius. There is in excavation some grooves making space for the scaphoid, and this is on the other side. So they are bilateral but asymmetrical. Okay. Joints are involved. Can you see any erosion? No, you don't have to see. So sorry. Can you see any calcification? Probably not. But you don't need to see calcification when you see clearance. This is very typical of CPPD. Okay. It typically occurs after the age of 70. Looks like osteoarthritis, but you need to look area. So if you call it osteoarthritis, it's osteoarthritis, but the cause is different, CPPD, and it doesn't respond to normal things. Treatment is slightly different, but cause is entirely different. This is CPPD, not osteoarthritis. Okay. What happens, as I mentioned, what is this structure between the scaphoid and lunate? Ligament, scapholunate ligament. Exactly. So scapholunate is prone to tear because it becomes hard things very quickly. Yes. And then what happens to the space there just subluxes that area. And that leads to osteoarthritis, carpal row, or basically all of the things. So quite deformed. There is OH in the radius. Now, scapholunate ligament is capitate. Capitate is subluxing proximal, leads to osteoarthritis. So this appears called SLAC, scapholunate advanced collapse, SLAC. But this is much. Rest of the is okay. You know, radio and the radius is okay. Even on same thing on the opposite. Radius scaphoid osteoarthritis is slack, but this is really okay. So this is very typical appearance of CPP. Isolated radiocarpal involvement, as we can see here, which is in the ulnar ligament. It can be TFC, it can be these ligaments. Then distance is increased. Look at that. Capitate is relaxing proximally, and there is secondary osteoarthritis. We call it SLAC, scapholunate collapse. And if you report 20 areas of risk for arthritis, I think half of them reported how many PTs you get in the wrist. Not trauma, but arthritis. Now, this is associated with so look at that. Scaphoid is joint space is lost, not the rest of the wrist, maybe some calcification there, but you can see a big space. You can see cysts in the subcorneal space in osteo big, and so they thought it's a tumor. I think it's a giant cell tumor. We saw that there's a very very typical, and we had other signs of radius scaphoid arthritis. So CPPD because it subcondylosis formation. Another case, we didn't see that. I can't see. Let me just move it. Yeah. So maybe early radius scaphoid joint space. Sorry, let me just move it. Maybe early loss there, but most of it fine. Look at the calcium there. Calcification in the TFC area. The calcification here in the second MCP joint, maybe calcification. Whenever they think of CPPD, especially we see it in the wrist joint. So this is probably another case of CPP. Now, moving on to hand, rest of the hand. As I said, it involves the second and third MCP joint. Okay, like osteoarthritis. But what is the difference? Now, we mentioned very carefully that in the osteoarthritis, we see some osteophyte, and which is typically on the radial aspect. You can see it one here. Let's mag these up. Okay, we can see that some joint space is reduced on uneven, but you can see some osteophyte mainly on the radial aspect. You can see some irregularity on the ulnar aspect as well. You can call it erosion, but we decided in the first few slides irregularity is normal and we don't call it erosions. So you can see some osteophyte there, maybe some osteophyte because you can't see it. So these two joints, when you see like appearance, but with osteophyte, think of EPPD. Look at the wrist joint because in the X-ray, wrist will be included. You may see radius scaphoid abnormality, and you may see what we call some calcification of the ligaments. Okay, so in this case, similar appearance, we can see now these two joints, which is the second and third, all involved, and they are big osteophytes in that case, called as hemochromatosis. Basically, hemochromatosis is primary condition. It is leads to basically CPPD. So in that case, CPPD is secondary to hemochromatosis, where the deposits in the body. So it's the same radiologically, but it typically involves all the MCPs, especially third, fourth, and fifth, with OA and osteophytosis. So if you start seeing the CPPD appearance at all these MCP points, think of hemochromatosis because this is secondary CPPD. So in this case, we're not sure about what it is. So look at there is reduction, but rest of maybe a little bit widening of scapholunate, not much of a slack. Don't see much calcification. CP joints, they're okay. So it is osteoarthritis, is very common, but pain in the X-rays. It's that there is calcification in the joint, probably partly meniscal, partly capsular, maybe some calcification of tissues, and the patelliform is there and in the suprapatellar pouch, which is known presentation of CPPD. So you can use it as well to diagnose these conditions. So CPPD is calcification of the cartilage, tendon, and soft tissues, and the joint. It typically involves CP joint, just like radial osteophytes. For the wrist joint, it involves the radiocarpal osteoarthritis, which can lead to distance in scapholunate advanced collapse. It doesn't, but can occur, and it is bilateral. And if all space and fights. Rheumatosis produces secondary CP. So, any question about
A very beautiful
it? I know you have a
I just question, sir, in case a
your voice breaking up. Ashish. Ashish, can you type your question? I can't hear you.
Destruction of the scapulae ligament. So, how is it okay now?
No, Asha, I can't hear you well. Your voice is breaking up a little bit.
Am I audible now?
No, you're fine now. Yeah, go on. I can hear you now.
Sorry, disconnected. Sir, I was asking that what is the difference between the CPPD? Because one of the radiographs that you showed of CPPD, it showed linear dislocation in which the unit linear pie shape, exactly like linear dislocation as we see. So will we differentiate between linear dislocation and a case?
Very good question. Okay. Lunar dislocation will not occur in chronic cases. It will always be trauma.
Okay.
Number one. Number two, these changes here, although it looks because it's widened and dislocated medially, so that's why it increased. So it's funny because alignment of the joint is looks funny on you. Of course, I didn't show you the lateral, but trauma because always somebody show you and before you orthogonal view because it may posterior dislocation. It looks sometimes not be dislocated. Luxation can lead to funny appearance of lunate.
Thank you, sir. Explained.
Okay. But anybody, I just want people to type so I can and they can peek. But anybody who's not sure about type, so I know you sure that you everybody clear about CP can go over any sure about. It's not a problem at all. Okay.
I think we should go on. If there is any question, they would be inshallah in the chat and
I'll side with system. So I think you're talking about this. And because of inferior arthritis, because can cause inflammation like osteoarthritis. It's typically because of the crystal produce it's okay, it can occur any rheumatoid features there. So we see the scaphoid is not thinking that CPPD exists here. Exists there, typical of CPPD. So if anybody wants to start big cyst, knee joint see cyst, and C calcification, you can easily say nothing to worry about. This is just part of. It is quite common, but occur in elderly people. Not common in but not big cyst. So if you see big cyst, it is CPPD. You need to look for some calcification. Okay. Now, moving on. In the soft tissues, and they can also erode or extend into the bone. And these patients typically have high uric acid levels. So that is the basic thing you can see. Phenomena, but this is the baseline of it. Distribution wise, in the hands, can involve any joint. I know in the feet they have different distribution, but in hands it can involve any joint. Okay, and as we know that it can produce appearance, but in that case, because we know other conditions which can produce erosion in the interphalangeal joints. One is erosive, as we know, as we, and other is psoriatic or seronegative arthritis, which produce erosion. So either identify the typical erosions with this in a minute, or it can have symmetrical soft tissue or dense soft tissues. Swellings, which is asymmetrical always, because so anyone can be typical erosions and asymmetrical soft tissue. We know erosions because of tophi or crystal erode the crystal do not dissolve in synovial tissue, keep accumulating and keep on eroding, and they make a shelf that is the main. Usually they are articular, but they can also extend into the joint, or sometimes they look intra-articular. I love that picture that looks like intra-articular. They are usually extra-articular. Again, they can be intra-articular as well. So they can give this pushed out rat pie type of erosions, but hanging edges, when you can see the hanging of well-defined hanging edge is typical of gout erosion. Case, this is very destructive. You can see that there's all destroyed. Look at the margins, very well defined. This all is overhanging. It has the shoot. Same is here in the one of the main finger. And same thing. This is a APVs and dense soft tissues with erosions. So very typical of gout. It can involve any joint in the hand. Now you see here. Again, some people psoriatic arthritis. Yeah, it can look like that. But look at the erosion. It is very well defined erosion and extending into the bone, but overhanging edge is very of gouty arthritis. And of course, and you can see that the bone densities generally, if there is negative arthritis, to erosion. So if you see erosion in the big erosion in the DIP joints, rheumatoid is ruled out. The DIP joint, especially with the big erosion, it can be erosions, but common arthritis. So if you know your if you can easily exclude things on the basis of where they are located. Type of erosions, well-defined margins, multiple intra-articular extension, and soft tissue swelling, which is more prominent on this side, means this is typical of gouty arthritis. Arthritis can give this appearance, but we don't see that appearance. We don't. This appearance usually collapses central. There's no overhanging erosions, and usually not associated with swelling, which is asymmetrical. Negative yes, can be, but that doesn't give that this type of overhanging erosion. and margins of the bones is fuzzy. We have a very sharp margin that can be ruled out. So you have to magnify it or use magnifying glass. The whole wrist. It doesn't confine itself to the radiocarbon type. It involves the whole wrist. But one thing, if you think of TMT and CMC, is carpometacarpal joint, very prominent and big erosion, especially in the base of muscles or carpal bones. Sorry, metacarpals. So can involve, you can see the quite a bit of erosions, but the big erosion here is very typical of gout. So this appearance here can be due to rheumatoid. It involves the wrist. It loads of osteoarthritis. Sorry, it's loads of erosions. There is no reduced bone density, number one. Number two, this erosion is not typical of rheumatoid arthritis. Fan compartment involvement, but large erosion metacarpal base is typical of gout. And in rheumatoid, of course, can give appearance, but osteoarthritis, that erosion, especially in the metacarpal base, is now patient who can see osteopenia, which is more common in rheumatoid than gout. There's big hair and maybe some erosion in rest of the. This where the big not common in rheumatoid can occur, but not common in rheumatoid. And we did the uric acid, and it was patient was negative for rheumatoid, uh, rheumatic factor or other things. So gouty arthritis. So why osteopenia there? Osteopenia, and patient is the risk. Osteopenia, you can see that reduced bone density. In patients, we can see that erosions are much more common, although plain X is much better, but you can see that erosions are much more common basis as compared to the rest of the bones. Another case, we were not sure what it is because there's some calcification. Some radius space is reduced, some calcification here as well, and we can see some big erosion there. Typical or hanging edge calcification. So it is pseudo gout because we can see calcium or post gout. So we did uric patient also had a uric acid rate. So we thought patient has a CPPD as well as overhanging erosion, suggesting that there's gout, soft tissue swelling as well. So sometimes we can have the circle I showed you in the beginning, they can be overlapped or they can coexist at the same time. As we know, it's typically involves the big toes, and as I mentioned, it can involve TMT joints, CMC joints, and TMT joints in the foot. No erosions, space is maintained in this, and there's a big dwelling which is on the outer aspect. Completely opposite. We can see that overhanging edge. This is very typical where the not elevated overhanging edge. Similar thing here, and a big soft tissue swelling and extension here. In AP, if you do the lateral, we may some erosion on the other side. And another thing is here, early erosions in the IP joint. So multifocal to gout. Is normal, but there is an erosion, a hanging margin, find maybe a little bit of reduced bone density, but soft tissue swelling, which is asymmetrical, gouty arthritis. So we did something else. I don't know why we didn't see the erosion is all across medial side as well as lateral side, but erosion is mainly on the aspect. It doesn't add anything, just want to show you. And same thing as CMC joint, it can involve the TM joints. You can see the big erosions there. Rheumatoid can do that, but TMT joints is not that much involved, especially if you see this type of that is typical of gout in the midfoot joints. That in my conference, your conference over there, we had a gouty soft tissue. Right, I'm saying mass could be anything. It can be just tendinosis, or it can be rheumatoid, but patient has typical erosions in the TMT joint, the lateral TMT joint erosions. In rheumatoid very often, and gout. So remember all these things. So in summary, any hands in the hand, but in the DIP joints, we need chills like osteoarthritis or seronegative osteoarthritis, asymmetrical dense soft tissue masses. In the wrist, we have the whole generally, but we see a big erosion in the metacarpal basis or CMC joints involvement, and in the foot we use corresponding TMT joints involvement, which is not very good. So any question about? We stop here. Anybody please, and we will discuss, go over it again. Is it Najib? Your voice is breaking up? Or is it Aisha?
So no questions so far. Everything was beautifully cleaned.
Okay. Good. So what will, whenever we get time, we do the rest of
Me, Aisha. And
Yeah.
I think I have my internet is unstable today.
Okay, no problem. So what we'll do is, if nobody has a question, in next week we just quickly revise and then we move on to rest of the arthritis. And from there on, once we've done that, then we go through a few examples and we can move to the big joints. So it may be a series of maybe 4 or 5 talks or 4 or 5 sessions where we can hopefully get some idea how to interpret these things. Yeah, I'm still here. I've got 5 minutes, so we can, any question we can type anything. Did you have any parallel lecture going on? Was just not some other lecture going on?
There was a pre-recorded session which is.
All right. Okay. Oh, sorry about that. I didn't realize that.
I guess it finished by 12.
Okay. ठीक है. Everything is fine. Nobody has. So hopefully. Updates of these lectures means, what do you mean by that? Update about the next section. Somebody, Zainab asked this question, from where we get the update